All right, everyone. Welcome back to our fourth installment of the High Yield Rapid Pharmacology Review. This is Mike Fiore, and you'll be hearing me a little bit later. As always, we just want to let you know that we're not working in conjunction with school. We're totally independent of anything going on at school. We're just a couple of guys who like talking about pharmacology, who are giving you what we think is our best guess as to what'll be on the exam, and you should still look at the notes and all that other stuff. So take everything we say with a grain of salt. All right. So this is actually the point at which last year we gave our first review. This is the first review we gave last year, and one of the things we just want to reiterate, I'm sure you guys know that, I'm sure you probably have all of the old reviews we gave last year. From the previous class or what have you. We're gonna be updating them, so you can use them for to help you study if you want to get an edge, but always keep an eye on the lookout for the new reviews when they come out, because we're going to be updating them, making them a little bit better as we progress throughout the year. We learn different things and how to make the reviews better. So this is an updated version of the one from last year, so there are changes in it. You'll notice if you have the old one, there are new changes. So try to use this one or download the new document. So one of the things we did that we didn't really do in the beginning of the year with you guys was there are a lot of questions. So most of the questions that you'll see going forward are from the question bank USMLE RX. Mina and I really liked that because there were a lot of good pharm examples that we found as we were going throughout the year that we could incorporate and help you guys. So this one's this is a question that's really meant. This was the very first thing we did for the class last year, my class, and it you'll get the point. You'll get the point as we go forward. So, question. So, 45-year-old male presents to the clinic for an annual physical, history of hypertension controlled by hydrochlorothiazide and metoprolol. After 2 visits with a BP greater than 160/90, he's prescribed a transdermal medication to provide additional control of hypertension. The patient is counseled about the importance of being compliant with the new medication, as suddenly stopping this particular drug can lead to a sudden, severe increase in blood pressure. So the question is, which of the following describes the mechanism of action of this transdermal medication? Is it A, an alpha-1 antagonist, B, a beta-2 agonist, C, a beta-1 antagonist, or D, an alpha-2 antagonist? So I'll give you a few seconds to, try to figure out, see what you think it is. So I'm sure a lot of you, maybe most of you, picked C, thinking that it was, most likely metoprolol. We talked about this last time. It is a beta blocker, and abrupt withdrawal will cause rebound hypertension. However, the answer is actually B. It's an alpha-2 agonist. So the key point here was this is a transdermal medication, and the transdermal medication is referring to clonidine, which comes in patch-like form. So according to USMLE RX, 36% of students got this right. So this was a very hard question, one of the ones that you sort of wouldn't be able to answer, because it would, you'd have to know that, clonidine and metoprolol, clonidine is a transdermal patch and metoprolol is an oral medication, which is something they don't really, talk about in class. But so now last year what happened was we actually asked this question to the class, and every single person put their hands up for C, and it was actually very funny because I was tricking them on purpose, but it sort of got the point across that you can memorize different facts, but what we're going to try to do is we're going to try to give you a little bit of an insight into the different things that may also be important that you may not think about. So the fact that clonidine is a transdermal patch, they may ask you a trick question like this, and something that you didn't study or you didn't realize was an important fact comes back and is an important fact. So the whole idea of this question was, don't feel upset if you got it wrong or anything like that, because obviously most if not all of you probably did get it wrong, but in comparison to your colleagues around the country who didn't listen to this review, you guys now know that clonidine is a transdermal patch, and going forward, you'll never get that wrong again. So, we're going to give you some of the best information, some of the sort of inside tips and tricks that you may not hear elsewhere, and hopefully it'll help you going forward. So, lipid lowering agents. Very, very fun topic. So you'll be seeing this stuff everywhere. Now, this is a slide from first aid. It's sort of going over all of the different mechanisms by which we can lower our different lipid levels. So we'll sort of go in order. Number one, what is seems to be an inhibitor of creating HMG-CoA into melavonate acid, what is the mechanism and the drugs that work on this area? If you guessed statins and HMG-CoA reductase is the mechanism, you got that one right. So number two, what is inhibiting the cholesterol conversion into very low density lipoprotein and is also inhibiting lipolysis of adipose tissue? If you guessed niacin, you guessed correctly. This is a little bit of a trickier one. Number three, what is actually increasing lipoprotein lipase, increasing the amount of free fatty acid that we have created? These are our fibrates. Fibrates are upregulating our creation of free fatty acid. Number four, what is inhibiting cholesterol being absorbed in our GIT? If you guessed Zetia or ezetimibe, you got that one correct. And last but not least, what is inhibiting bile acids from being reabsorbed in our GIT? With, it's in its name, there are bile acid reabsorption agents such as cholestyramine, cholestyramine, and cholecystyrene. Those are our bile acid resins. All right, so just going down the list. First, we have our statins, probably the most high yield, biggest, most important drugs in this section. So statins inhibit the HMG-CoA reductase enzyme. So we inhibit the HMG-CoA into becoming melavonic acid. They're broken down into different categories based on the new guidelines, high intensity being atorvastatin and rosuvastatin, medium and low intensity being all of the rest, lovastatin, pravastatin, simvastatin, fluvastatin, and there are a few more that aren't included here. As I said before, you're inhibiting HMG-CoA reductase enzyme. So what this is doing is it's actually increasing the hepatic expression of the LDL receptor, and so therefore you're increasing the LDL getting taken into the liver and being cleared from the blood. So this is going to maximally reduce your LDL cholesterol, and it's also going to cause an increase in your HDL. Primarily used for hypercholesterolemia, but you're also going to see them being used in after somebody has a coronary event, somebody who has coronary artery disease to prevent a coronary event, and then after having a stroke or in prevention of a stroke. So they're used quite unanimously in the medical world to not only lower the amount of LDL cholesterol, but in a sense for primary prevention of and secondary prevention of a whole host of different things. So you'll see them used a lot, and in their use, it's not necessarily the way they're prescribed now. They're not really used to actually lower LDL. You're not looking for a number. There are many different guidelines through the last 10 to 20 years that, what's a good number for your cholesterol to be. First, they thought less than 200 for your total cholesterol was what we were shooting for. The guidelines previous to the current ones thought, you need to be less than 100, and then if you had some risk factors, you needed to be less than 70 for your LDL. Nowadays, we don't even check numbers as much anymore, and we just say, if you have these risk factors, you need to be on a high intensity, and if you don't, you can be on a medium one if you fit this age range. So, there's a lot of differences in when to give them and when not to give them. So just don't worry too much about that. what you're worried about now is, you're going to lower your LDL cholesterol, you're going to raise your HDL. They're used for a whole host of different things, and we have some high yield side effects. Number one being they're going to raise your liver function levels. So you're going to get ALT and AST increases, and if they get too high, greater than 3 times their normal, you want to stop the statin. In addition, very, very, very high yield drug interaction with fibrates, which we'll talk about in a second. So statins inherently can cause some myopathies and muscle pains. It's one of the things that you'll counsel your patients when you put them on a statin. Let me know if you have any new muscle aches or pains in your legs. This can get to the point that is so bad that you can develop rhabdomyolysis, which is the destruction of your muscle cells and the leaking out of the creatine kinase, which is the main indicator for having the problem. So you're at especially higher risk of developing myopathies and rhabdomyolysis if you give a patient concomitantly fibrates and statins. So very, very important. Statins cause myopathies, can eventually cause rhabdomyolysis if we're one of the unlucky percentage of people who can develop it, and then you're at an extremely higher risk if you also give them a fibrate. All right, some other agents. You won't really see these used as much for hypercholesterolemia or just primary prevention, secondary prevention of coronary or cardiovascular or cerebrovascular outcomes. You're mostly going to be using statins, and that's what you'll see. There are other agents that aren't well defined in the guidelines that we know do certain things, but they're just not used as much because they're not mentioned in the guidelines. First and foremost, what we just talked about, the fibrates. These are fenofibrate and gemfibrozil. So these are PPAR alpha agonists, which downstream effects lead to increasing lipoprotein lipase, as we said before, which will help break down our VLDL and our LDL into free fatty acid. So they're primarily used for reducing triglycerides. So you just want to remember fibrates and triglycerides. So for example, if you have a patient with extremely high triglyceride level, you'd put them on a fibrate. Or if they're having a triglyceride-induced pancreatitis, we can put them on a fibrate to reduce the triglyceride level. So just link those two things together. Side effects, as we said before, myopathies. They are primarily going to cause muscle pains. Finally, as I said before, drug interactions with statins. Gemfibrozil and simvastatin are actually one of those, must not do complete contraindication. So you do not want to mix fibrates and statins together because they are putting your patient at a much higher risk for having myopathies that could be eventually developing into rhabdomyolysis. Our next class are our bile acid resins. So we have a few here listed. So specifically in its name, they're bile acid resins, bile acid sequestrants. So what we're doing here is we're actually causing an increase in the clearance of your bile acids. Therefore, your body has to make more of them. So if your body has to make more bile acids, it's going to be using more of its actual, cholesterol inherently to make more bile acids. And by doing that, that's actually how we're reducing the bile acids, or reducing our cholesterol by having to make more bile acids. Because as you know, because of enterohepatic recirculation, you actually reabsorb about 95% of your bile acids. So, we're excreting our bile acids by binding it to a resin, and by secreting our bile acids, we're having to generate more, and that is going to reduce our cholesterol, or LDL. The big thing with them that you'll see on tests is there are lots of interactions with absorption. So obviously, if we're giving you a resin or a binder, if you take any drug with that, there's a possibility that that drug could become bound to the resin. So very important to remember when you're counseling your patients and for examinations, you want to space out giving a resin and taking a drug. So if you're going to be taking another drug, you want to take that drug an hour before you give the resin, or you want to wait 2 hours after you take the resin. Very, very important, or else that drug's efficacy could be extremely reduced because it binds to the resin. Side effects, primarily, GI disturbances. These drugs aren't absorbed systemically, so they're just going to be causing some, some flatulence, bloating, and constipation. Niacin, nicotinic acid. So this is our vitamin D3, and its MO is that it can actually increase your HDL. So as I said with fibrates, no triglycerides, I want you to memorize that niacin can increase HDL. You see a question and the patient has all these problems and they have a very low HDL, look for niacin because that's the answer. The big thing with niacin are some of the side effects being flushing and itching. So I believe it's because niacin is a precursor for it's a precursor for serotonin or histamine, and because of that, when you take it, you actually have an increase of one or the other. Now, to reduce this, we actually give niacin with aspirin. So if you give niacin with aspirin, you will have a reduction in the amount of flushing and itching that you get with its administration. You can also give it in an extended release form. Additionally, niacin can also cause glucose intolerance. Last but not least, we have a few adjunct agents. So we have our cholesterol absorption inhibitor, ezetimibe. So this is sort of like the bile acid resins, only instead of binding to a resin, we're actually blocking a transporter in your gastrointestinal tract, and that is inhibiting the absorption of cholesterol through the gastrointestinal tract. So this is an adjunct for patients on a statin already. You don't really give this alone. I have a lot of stuff here written about monotherapy and adjunct. So we'll talk about that a little bit later and why some of these things are or aren't used as we go over the big picture at the end. Finally, we have our PCSK9 inhibitors. These actually came out very recently. I think the first one was approved in 2015, 2016, which was actually after I graduated pharmacy school. So it's very true that medicine is changing all the time. So I was never taught what these drugs do. I had to go look them up on my own time and figure it out. So you're going to be constantly learning because clinically relevant things will happen all the time after you graduate, after you leave residency, and it's going to be on your you're going to have to take charge of your learning and your keeping up with the times. So these two new drugs are monoclonal antibodies, alracuramab and evacluvimab. So these actually inhibit the degradation of the LDL receptor. So the idea is PCSK9 binds to the LDL receptor on the liver and it marks it for degradation via lysosomes. The way this was discovered was, you have your patients with familiar hypercholesterolemia, which is the absent or defective LDL receptor. Therefore, you have LDL building up in your arteries extremely quickly, and you have these patients in their early 30s and 40s suffering from massive heart attacks and having, horrible atherosclerotic disease. So they figured out that this PCSK9 is actually causing the destruction of the LDL receptor. Well, maybe if we inhibit the PCSK9, we can increase our LDL receptors and recycle them so that we're constantly taking the LDL protein and cholesterol out of the circulation and bringing it into the liver. Because of that, they actually found that they were able to drastically reduce LDL levels in the blood and prevent cardiovascular outcomes like MIs in these patients. So it's specifically used for familial hypercholesterolemia, but we have patients with horrible cholesterol, and now we have this new drug. While it's very expensive, patients with uncontrolled disease can actually be placed on a drug like this in addition to a statin. Now, because of its cost, it is a monoclonal antibody, and that statins are very, very efficacious. We don't really use this as much in addition to a statin, but know that it's there. These are going to be primarily for those with the severe familial dyslipidemias, specifically familial hypercholesterolemia, but it's another it's another drug that we have, another tool in our toolbox to treat some of these patients. Now, sort of a little big picture slide for lipid lowering. As I said before, how are we going to raise or lower our lipid levels? So to lower our LDLs, the two strongest drugs that we have are statins and the PCSK9 inhibitors. You're going to primarily only see statins used, but if we have a very sick patient who for whatever reason is not able to tolerate statins, or it's just not getting the job done, we can also use the PCSK9s. We have drugs that have some moderate effect at lowering LDL levels, Zetia or ezetimibe, bile acid resins, and niacin. And I will go into the guidelines on the next slide to talk about a little bit more about when we use any of these. As I said before, triglycerides, just remember that we're going to use a fibrate to lower your triglyceride levels for whatever reason. And to raise HDL levels, we're going to use our niacin. Now, so in, I think it was 2014, they came out with it was 2013, my bad, was the new guidelines for statin therapy or for cholesterol therapy. And pretty much what they said was, if you have one of these four, if you fall into one of these four categories, you're going to get put on a statin. And that's all they said. So all of these drugs we talked about before for lowering LDL cholesterol, when your LDL is high, we don't really use them because there isn't any information on the guidelines as to say when should we use them. All they talk about are statins. So you have a patient with an LDL cholesterol that is greater than 190, you start them on a statin, and it's going to be a high-intensity statin. But you don't need to worry about that. You just know we're going to start them on a statin. If you have a patient who's a diabetic between the ages of 40 to 75, we're going to start them on a statin. So they also have something called the ASCVD, clinical ASCVD. So that's just saying that you have a patient with a coronary artery risk equivalent or coronary artery disease. They're getting a statin. And then finally, this was sort of the controversial part of the guidelines. Patients between the ages of 40 and 75 with an LDL between 70 and 189, they're going to get a statin. So this is that primary prevention area of coronary artery disease, or sorry, not coronary artery disease, but coronary, having a heart attack, having an MI. This is what we're trying to prevent with this age group, and this pretty much, this hit everybody, because for the most part, most people have an LDL greater than 70, and if they're between these ages, they're going to be put on a statin. So this is where we, got a little bit hairy with, the guidelines, and a lot of them were written by people in the big drug companies who also work for some of the companies that make the statins, and a little bit of misappropriation of funds, and big pharma stuff that we all hate. But regardless, this is how we're treating patients now. As I said before, we don't really use some of the other drugs because they're not really indicated in the guidelines. So we sort of figure out if you are in one of these categories and we put you on a statin. There are some other things that go on over here, but that's really above your level at this point. You don't really need to worry about the different kind of statins and whether they're high intensity or low intensity or things like that. You just remember this.